Hello, 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 everybody out in Facebook world. Thank you for joining us today for this very needed conversation about COVID-19 vaccines for the Black and Brown queer communities. Um, we are super thankful and very happy for our two presenters today, Dr. Stefan Wallace, as well as Kay Martinez. This is a collaborative event between the Center for Black Equity, where I serve as a deputy director, and the Latinx History Project. Over to my, I'm going like this, but she's actually, okay, let me do that way. Over there to Nancy Canas. Do you want to?
Yes, hi. It's Nancy Cañas. I am the president of the Latinx History Project, and I feel like we're the Brady Bunch. So thank you everyone for joining us.
Yes, thank you, thank you, thank you. So if anyone is watching us online, please share this live in your groups to your friends, because we're going to talk about some things and we'll also be opening the floor for questions. So if you have any questions about the COVID-19 vaccines, this is your opportunity to talk to some experts in the field to get your questions answered. Feel free to post your questions in the chat box on whatever platform you're watching on. I know we're currently streaming on the Center for Black Equity as well as the Latinx History Project's Facebook pages. So please submit your questions and we'll do our best to get them answered. So without further ado, I will go ahead with the first question that we have loaded. Um, and either Stefan or Kay can jump in this. Both of you can answer it actually. Um, do you think the lack of Black and Brown people's involvement in clinical trials has affected the lack of uptake of the COVID-19 vaccines? Anyone can go first.
Um, I guess I would say yes. I think that the history of research in specific communities, in particular communities of color, has impacted the acceptability and acceptance of the COVID-19 vaccines, plural. I would also say, though, that I think um, I would probably venture to speculate that a proportion of that resistance to the vaccines is also connected to everyday experiences of racism by communities of color, in terms of medicine, in terms of medical establishment, engaging doctors and providers, as well as systems. The unarmed killing of Black people continues, and other
Yeah.
issues of systemic racism, I think sort of overlay, this topic as well.
Okay.
I think it's a part of it. So I think part of that logic maybe thinks that if more Black and Latinx people were included in the clinical trials, then it would have created more trust in going to then be vaccinated. But then what we're seeing now across the country is a lack of access to the vaccine, particularly for Black and Latinx people. So I think, we're dealing with not only the very justified skepticism based on a long history of medical racism and medical anti-Blackness, but also now what I consider to be an intentional effort that is not giving our communities access to this vaccine. So I think a lot of our people want to be vaccinated, but don't have access to it. And we're being forced, speaking more concretely about Latinx people across the country, to work right now in very unsafe conditions, not having adequate protection, and that is endangering our lives. So I don't know if you were to ask these essential workers if they would like to be vaccinated, I think a lot of them would say yes, because I have to go to work right now, but they are not a priority.
Right, right. And access has been something that has
Can I
no.
make a really quick comment about that? I wanted to provide some additional thought about my initial comment as well. because I think it's somewhat related, that historically communities of color have been left out, excluded from research, except when it's not benefited us, right? And I think that what has happened with these clinical trials, and what we have done as a network through our relationships with longstanding community partners, across different race and ethnic groups, including Unidos US, Latino Commission on AIDS. We work with the Mexican consulates and lots of other groups. But the point I want to raise is that I think the work that's been done has supported diversity in the vaccine trials that have resulted in the EUA for Moderna. And you know, we're seeing greater diversity in the trials that are following, including in Janssen and Novavax. So for Moderna specifically, I just want to highlight that 20% of the 30,000 plus people involved in that study identified as Hispanic. That's a huge accomplishment. And about 10% of the study population was about African American and Black. So those are numbers greatly above what we've seen in clinical trials historically. But for me, they don't represent the ceiling, they represent the floor. And so how do we also work with communities to ensure that the representation of communities of color, particularly Black and Latinx persons, are represented not just by their population size, but by the burden of disease in these communities.
Thank you for that. Thank you for that. You know, I realized I jumped right in without letting the audience, I know who you all are, but the audience doesn't know who you all are. Could you just take a second just to introduce yourself and the work you do, you know, around this topic?
Sure. My name is Stefan Wallace, and I'm a staff scientist here at Fred Hutch. It's a global cancer research center. I'm also the director of external relations for the COVID-19 Prevention Network, which is in the HIV Vaccine Trials Network. Both of the networks funded by NIAID, so Tony Fauci's shop. And, you know, the work of the COVPN, or the COVID-19 Prevention Network, has largely been leveraged from the existing relationships, capacity, and expertise of the NIAID-funded clinical trials networks. I'm also a clinical assistant professor in global health at the University of Washington. And I am a legend in the House of Ball community. I am the board chair of the House of Blahnik as well, so.
So thank you.
Hey everybody, I'm Kay Martinez. I use they, them, theirs pronouns, and I'm in Boston, Massachusetts. For the past year, I have been working at Massachusetts General Hospital's Institute of the Health Professions. So it is a graduate school for medical students affiliated with MGH, or Mass General Hospital. And there I was associate director of our Justice, Equity, Diversity, Inclusion office. I also created a course on JEDI for the health professions. Also, shout out to the folks who got multiple jobs out here. Down the street at Harvard, I was a teaching fellow on critical race theory and education. So my work has largely been in education, right? Working with health professionals, talking about these justice issues. So issues of access, how we're seeing these intersections of race and class play out in COVID-19, and creating curriculum to address those matters. And I just want to say as a side note that I also live in Chelsea, Massachusetts, which is a predominantly Latine neighborhood. This is the epicenter of COVID-19 in Boston. I was also fully vaccinated 2 weeks ago. I was able to take the Moderna vaccine. So yeah, that's where I'm coming from.
So thank you. Thank you both. All right, so the next question we have, we've never heard such an emphasis before in Black and brown people to get a vaccine. Why is it that way now with COVID-19?
I feel like uh, because this country is invested in getting back to its business as usual,
Mm,
and Black and Latinx people are the workforce, right? We are essential workers, and we largely have been working this entire pandemic. Not all of us have the luxury of working from home. You look at the folks who are working in grocery stores, for example, migrant workers, farm workers in California, for example, they are Latino people. The country needs them. They are the drivers for this country, Black folks as well, doing this essential labor, right? Uh, but not being treated or respected as essential people. They're not getting hazard pay. It's been a
mm,
very controversial issue. They did not get adequate PPE, right?
mm,
But yet required to work. And then we saw this whole political campaign around protecting corporate liability,
mm,
right? Making sure that corporations could not be sued if and when their employees got COVID-19, which, is a dominant Black and Latino workforce.
mm,
So I think the emphasis on getting this vaccine out to people in mass in general in the United States is so that we can go back to business as usual. And the only ways that Black and Latino people are getting this vaccine is so that they can continue to go back to work, even though they're already working,
mm,
to keep the country going.
mm.
Frankly,
Thank you.
this isn't about them caring about us as people because they don't. This is about us being able to work.
Yeah, thank you for that, Stefan.
Yeah, I'm not sure who the they is that Kay is referring to. That's really amorphous, and so I'm not sure if that was intentional or not. But the scientists and the communities who've been actively involved and impacted that we've been engaging are very interested in seeing communities of color uptake the vaccine because we're the communities that are dying at higher rates. We're the communities that are being hospitalized at higher rates. We're the communities that are being impacted by not being able to go back to normal and being impacted by the already existing impacts of systemic racism that has resulted in many communities having less access to equitable paying jobs that offer the benefits that would allow people to take time off from work and have childcare and all the other benefits that are typically associated with corporate jobs, right? So physical distancing and and working from home is a luxury, and I think that sort of relates back to the point that Kay made that these issues of systemic racism and classism completely underscore and really overscore what we're seeing with in terms of the pandemic. And I think for many people, the desire is to minimize the continued impact of COVID-19 and the virus that causes it in our community. So the vaccine is absolutely one way to that aim.
Thank you.
Well, thanks, Dr. Wallace. Just to clarify or unpack the they, right? There's many theys. So the theys that I have seen that are encouraging Black and Latino people to get vaccinated are Black and Latina people. So here in Chelsea, for example, right? I mentioned this is the epicenter in Boston. Initially, when Massachusetts was rolling out its vaccination plan, we recently got an F uh, based on a rubric that Harvard University came up with that was evaluating each state's rollout plan vaccinations. Massachusetts is in the very low end of statewide distribution in general. So I want to put that out there. Chelsea, Massachusetts was not even given its own vaccination center, if not for the work of Latina organizers in Chelsea who pushed back and said, we need our own vaccination center here. And so, to Dr. Wallace's point, that community of people from Chelsea who are also Latinos want to protect their own people and get them vaccinated because they are being forced to work,
Mhm,
right? They are low wage essential workers. Now, at the same time, there's another they that doesn't care if those employees get vaccinated. And those are the people who own those businesses. I'm thinking specifically about grocery stores. We had Kruger over in the West Coast that shut down multiple store chains rather than give their employees hazard pay. right? So there's a they that doesn't care if you get vaccinated or not. And then I think we are our own theys that are making sure that our communities get the vaccine because we know that we're being put at risk. Also, I'm thinking about the work in Philadelphia. It's a Black Doctors Consortium. They have specifically created vaccination sites for Black residents of Philadelphia. So, I think they want us to get vaccinated. They want their own community to get vaccinated and are prioritizing the Black community when nobody else is in terms of vaccination outreach. I hope that clarifies.
That is absolute clarification. I think I think that nuance is really helpful because I often find myself in conversations and there's a reference to a they, some sort of amorphous being or beings out there. And I think being able to, for people who are listening to this conversation, I think it's really important that they are able to walk away from this conversation understanding that there are people out there who are part of our communities who are working really hard to save our lives because the system has shown that it's not in support of us in terms of our health and wellness. And so that's the clarifying point that I was hoping you would make.
Awesome. Thank you both. All right, next question is for you, Nancy.
So we've heard about herd immunity, and my question was, how does that actually work, and what percentage of the population would need to be vaccinated through or have the antibodies to, I guess, have the herd immunity that we've heard so much about? And I know, Dr. Wallace, you want to jump on this one.
Yeah, this, thank you for the question. This question is a really interesting one. And when I think about it, I go back to one, being transparent about what it is that we know and what we don't know at this point, right? And what we know is that both the Moderna and the Pfizer vaccine are approximately 94 to 95% effective at preventing moderate to severe illness. What we do not know yet is whether these vaccines or the other ones that will come down through the EUA will protect people from acquiring the SARS-CoV-2 virus or transmitting the virus should they acquire it. So because of that, it really complicates the question around whether we can achieve herd immunity, because really herd immunity is about vaccinating a percentage of the population so that the virus has nowhere to go to continue to impact people. So there's not a lot of room left in the community for the virus to continue to go and continue to multiply. But because we don't yet know whether or not virus transmission and acquisition is possible by the vaccines, to me is sort of a premature conversation to have about herd immunity at this point.
So here's another one for you. So if someone has had COVID, should they still get vaccinated?
They absolutely should. I think there's a misnomer or a misunderstanding about what this virus represents because of how it was reported many times by media early on. This is not like the flu, actually. And so just because you acquire the virus and you may or may not have symptoms, if you acquire the virus again, you could. And just because you get COVID-19, the disease, one time does not mean that you can't get it again. So the goal here is to minimize symptoms and to minimize people having symptoms to such a degree that they find themselves in the hospital, on a ventilator, or even dead. And so getting the vaccine is crucial to do that. And it's not the only strategy, but it's definitely one of the strategies to do that. So I would absolutely say that people who have had COVID-19 should get vaccinated. They should wait the recommended 90 days until after they're no longer symptomatic before they consider getting the vaccine.
I'm going to actually jump in. Could you explain why they should have to wait those 90 days? And Kay, you could jump into as well if you like. Yeah, why? Why 90 days?
Sure. There's two reasons. One is because after a person acquires the virus, their body is going to develop an antibody response. The challenge is that that antibody response has a term, and the antibody response isn't broad enough or specific enough to effectively do what it needs to do. What we do know is that the response does wane, and it will wane about 60 to 90 days after. So waiting the 90 days is to ensure that that particular antibody response has sort of moved on before you prime the body for another antibody response.
Okay, that makes absolute sense.
Yeah, I am not the medical expert here, so all medical technical questions are deferred to Dr. Wallace. Thanks for sharing.
Okay, no problem. Thank you. Um, and I think, Dr. Wallace already answered my next question. So I'm going to skip on. And so if you can, in layman's terms, tell us how the vaccines actually work.
That's a really, really good question. So, and I appreciate you saying vaccines, because oftentimes in these conversations, people are using the singular form of the word. Um, so we have two vaccines under emergency use authorization now, and they work basically the same way. They basically take a script or code, if you will, of how to create I guess I don't know if it would be helpful to show a slide, but everyone won't be able to see it. But anyway, so on the outside of the SARS-CoV-2 virus, there are spike proteins, and the spike protein has been determined to be the weakness of the virus. So what the vaccines are attempting to do is to teach the body how to recognize the spike protein in order to then teach the body how to respond to it, how to fight it, and how to cripple it. So the messenger RNA vaccines use a code or a script, basically instructions. The instructions basically come into your cells and your body, and the cells in your body read the instructions, its own machinery. Your cells have machinery that does this. So our cells read the instructions. Our cell's machinery then creates the spike protein. The spike protein then gets pushed out of the cell to the external sort of outer layer of the virus shell. So two things happen at this point. One, the messenger RNA instructions or script begin to degrade. And two, after the spike protein is expressed, our immune system begins to recognize that this is not supposed to be here. This is a foreign invader. We need to make sure that we're calling in, all the troops to fight this, to make sure that we do that. So that is part of how our bodies learn how to fight the virus. The spike protein that gets expressed degrades after about 48 to 72 hours. And the mRNA instructions or script degrades after about 24 hours. So none of these components really stick around in our bodies very long. And the ingredients of these components are and I don't want to oversimplify here, but we're basically looking at a fat capsule. They refer to it as a nanoparticle capsule. Mm-hmm. The mRNA instructions are inside. And then that fat coating is not from animal fat. It's actually manufactured sort of protein. So it's not coming from animals or anything like that. So just wanted to put that out there also, because I've had conversations with persons in the Muslim faith about that. So and then there's some different kinds of salts to ensure that when the injection is given, that our pH balance isn't thrown off, because if it is, then our immune system will actually attack the vaccine itself as opposed to, so we want to maintain our pH balance. So the salts in the vaccine help to do that. And then there are some sugars in there as well, which help to preserve the vaccine to be able to do what it does. But if you recall hearing probably many times in the media, the messenger RNA vaccines have to be kept at a cold storage temperature that is extreme. That is another reason why these products degrade in the body rather quickly, is because our internal temperatures are much hotter, and it won't allow the vaccine to sustain much longer. So it literally goes into our muscle, it enters our muscle cells, but it doesn't go in far enough to be able to impact the nucleus of our cells. So it can't interact with our cellular DNA at all.
Wow. Thank you. I get it now. I get it now. Thank you for that. Thank you for that.
So those are the messenger RNA vaccines. The other vaccines that are being tested through Janssen, AstraZeneca, Novavax, and Sanofi, when that vaccine trial starts, those are using protein-based vaccines, which we've used for decades and actually centuries in different kinds of vaccines. So those are basically taking, instead of putting the script in your body so that your cell creates the spike protein, the spike proteins are created in the lab, and they're basically given into our bodies through a harmless cold virus, if you will. We call it a vector in the science space, but it's basically an inactivated cold virus. And part of that is to deliver the spike protein directly for your immune system to sort of still recognize and respond that it's not supposed to be there, and it still go through that same sort of process to learn and to remember, so that should you encounter this virus in the natural environment, going about your day, again, thinking about case point, being essential workforce and having to be out there, to do the job in order to sustain our livelihood, then you would be protected, because you would have, your body would recognize the virus should you come in contact with it.
Awesome. Thank you for that. Thank you. Actually, and I know the next question is actually Nancy's, but I have a follow-up question to that. So I've been hearing a lot, because I'm learning all of this as well, just like everyone out there. If you're watching on Facebook, post your questions, get them answered. We have the experts here. I've heard this from some family members and some friends. They're eager to get the vaccine. Well, they say they're eager to get the vaccine so they don't have to wear a mask anymore. That I've heard that a lot. Can you talk about that a little bit? Like, why? I mean, if they got this vaccine, they're supposed to fight against the virus. Why do they still have to wear masks?
Yeah, that's a really good question. And I did mention this a minute ago. So I do think that it's really, really important for people to understand that we do not yet know whether or not the vaccines prevent a person from getting the virus or transmitting it if they get it. What we do know is that it will prevent a person who happens to get the virus from developing moderate to severe symptoms that would land them in the hospital and potentially, as I mentioned, on a ventilator or potentially dead. So that we do know for certain. We do not yet know whether or not it will protect you from getting the virus itself. So it is still extremely important that people continue to wear masks. CDC guidance right now is for double masking, and there's logical reasons for that. Many people aren't wearing a mask that provides sufficient protection. A thin, t-shirt is not sufficient to protect you from the virus and how it's transmitted. So I tend to do an analogy where if you put something over your face that you think is appropriate for a mask, or you're wearing a mask, if you put it on your face and if you can put your hand in front of it, if you can blow and feel the breath on your hand, your mask is too thin. So that's a good way to consider how this really works. If you can breathe through it, that means the virus can get through it. So yeah, that's really important to know. And so this is going to be something that people will likely be doing for a while. And I think it's critically important that we really think about how to do this, particularly with the variants that are upon us at this moment. And I don't think that the variants are cause for panic. I do think that the variants are cause of pause, because I think it's important to understand that viruses by nature are designed to survive and proliferate like living beings. That's what they're supposed to do. So as a virus continues to exist in a community, it's going to, as it continues to mutate, the mutations won't always be perfect. And that's how we get the variants. And so when these variants happen, and we have some already, that we're addressing and working on to compare the vaccines to, but I don't believe that the variants are over. We have a variant that was first identified in the UK and South Africa and Brazil and Australia, and by no stretch of the imagination should be assumed that this will be it, especially if the virus continues unabated in our communities or continues to move through our communities, because people aren't able to physical distance as much as they should or could. The structural and social factors that we've discussed so far in this conversation, in addition to the attitudes about masking.
Yeah, thank you for that. I really wanted to explore that conversation on masking. Kay, you wanted to jump in?
Yes, and I also have a question. So just yesterday, actually, there was a study out of UCSF looking at a Denmark variant that is moving rather quickly in California, particularly impacting Latinos there. And so for Latino folks, based on the data that I've seen, adding these like social, cultural aspects too, and race and class, right? Latino families tend to live together. They don't have financial means, right, to have a single person in an apartment. It's usually like 2 or 3 people maybe trying to split that rent. And then we have essential workers, right, who are working, they're becoming exposed, and then they're going back to their homes where they live with multiple people, and they're not wearing masks at home, and then it spreads. And where I live in Chelsea, this particular community takes a lot of public transportation. So you have folks on buses, very crowded, packed buses. So when this happened, the initial outbreak, that's why this particular community was hit so quickly. So all these layers just compounding. But my question for Dr. Wallace, I saw this story that 4 people in Oregon tested positive for COVID, even though they were vaccinated. So I didn't know if you could clarify on, how people who are vaccinated can still test positive for COVID?
Sure. I think of 2 scenarios. The first is I think they both depend on what the test actually is. So there are, sort of PCR tests that are looking for the actual virus, and then there's antibody tests. So an antibody test will likely test positive, because if a person has been vaccinated, then they would have developed an antibody response accordingly. A PCR test could be positive because a person could have acquired the virus, even though they've been vaccinated. So again, it goes back to the points I mentioned before about how critical it is to mask and to practice physical distancing and all of that as much as you can. And I think the other piece of this is there are different kinds of tests that are sort of circulating around. So some tests tell you whether or not you have sort of current acute infection, versus some tell you whether or not you've had a past infection. So I also think it's really important that people sort of, ask the critical questions when they're getting tested. What kind of test is this? What does it actually tell me? So that they have a little bit more of an understanding about what this means for them.
Thank you. Thank you both. Thank you both. All right, I'm done asking my questions. Nancy?
I wanted to ask Kay a question about building like curriculum, and how is this message being presented or conveyed to the medical professionals or those folks that you work with or the community that you're serving?
Yeah, so we've seen a really sharp increase in medical school applications given COVID-19, which I think is really inspiring. You see a lot of people, particularly Black and Latinx students, who are saying, I want to go into my community now. I want to help. And now with that surge of interest, as an educator, we want to look at COVID-19 and highlight and emphasize these racial disparities, the ways that it intersects, right, with race and class, for example. This isn't an accident. And unpacking those connections is where I come in as an educator of future health professionals, working with existing health professionals too, and trying to stay up to date with the latest information that is developing. Every day something changes, and so we're tracking this. But in terms of like the curriculum specifically, with what we're doing over in Boston and MGH, we're making the connections from today to the past, right? And the not so distant past is that. So folks have been making connections to Tuskegee, for example, but there's a new generation of folks who don't know what that is. And the skepticism around Black and Latino communities for going to get a vaccine, where does that come from? Well, there's a long legacy of medical anti-Blackness and medical racism and medical apartheid as well. But do people know that, right? And the examples that I've mentioned, right? Why is Chelsea, Massachusetts the epicenter of COVID-19, right? It's because of race and class. It's because of the way that folks here have to work and have to live, and their access to healthcare in general, right? So using what is happening today as a microcosm to look at all of the long-standing inequities that have been built in to our system, and then fighting against these systems, right? So one of the thems, one of the theys, right now, as I mentioned, Massachusetts, is this rollout that's happening right now. Who is getting access? Here we have different waves, different phases of people, and I mentioned before, it is among the worst in the nation. And we are seeing here in Massachusetts, but everywhere, that Black and Latina communities are not getting access to the vaccine, even though we are the communities that are dying the most, that have the highest infection rates. So as a teacher and educator who's talking about race and racism, we get new material every day. But are we being explicit about these connections? I don't know.
I think the equity issue and overlaying that with not just determinants of health, from a social perspective, but also from a structural and policy perspective, I think are really, really important. I really appreciate your comments, particularly when I think about, what is needed to really respond to this this crisis. And to me, it's not just how do we respond to it in this moment with this particular virus and this particular pandemic, but how do we impact the system so that the medical establishment is reimagining and re-envisioning how knowledge and the value that knowledge actually holds beyond people with academic training, but that community leaders are seen and viewed and are engaged in ways that affirm their knowledge and their leadership, and that we think differently about the people who come with titles and degrees and all of that. And so to me, there's a reimagining that needs to happen that I think is really important. I mentioned this earlier, as well as in earlier sessions with some other groups, including the CDC, that we need to deconstruct how we engage each other, and really center communities and really just eliminate all of these scaffoldings and all of these pillars and all of these silos. Like if we really put everybody at the same place and on the same stage at the same time, like how do we really think about this? What does this really mean? The other thing that I think about when I was listening to your comments, I think about the disabled community. And I also think about, the incarcerated population and, homebound older adults, particularly those who may live alone. Like there's a lot of sort of considerations that I think about when I think about the vaccine allocation process. So, at the federal level, they've ceded this autonomy to the states. And in many states, they've ceded the autonomy of distribution to the county health departments. So there's, to me, there's an opportunity to think differently about the allocation and the phases. Some of the recommendations that I've heard from communities is that, particularly with respect to communities of color, that we should, think differently about sort of the age, perspective, particularly when you think about the multi-generational households that Kay was referencing. So what does it mean to be in a multi-generational household, and the person who's 75 and older can get a vaccine, but not the other people who live in the same household who are younger. So there's a lot, I think, that needs to be looked at. And again, I mentioned that this is, to me, sort of systemic. This is not just about this particular issue and topic, but it's really about how we approach public health at a macro level, all the way through, how physicians are trained in medical school. How are they thinking about the approach to medical racism and engaging communities of color, thinking about the prior research and medical abuses that have occurred. So there's a lot there. So there's, a lot of work to do. I would love to be out of a job. And I don't mean to be tongue in cheek about it, but I do think that while on one hand, it seems like there's so much to do, I feel compelled to have some hope, because every day I seem to encounter people who have a new invested interest in this work, a new invested interest in studying in medicine, particularly, the historically Black medical colleges that are doing amazing at training sort of next generation doctors and physicians and healthcare providers. The nursing field is expanding and doing a lot of work to really recruit Black and brown communities into the nursing field. So there's a lot of reason to have hope, but I don't think that we need to sort of get complacent. The media referred to, what happened last year and the year before as a race reckoning. And I think that we really need to do a lot to galvanize the movement and take advantage of all of this new hype around race and equality, and really help move this forward. So.
Thank you. Thank you. Interesting, I saw a question pop up, but it's actually the very next question that we have for Nancy. Or you're muted, Nancy.
Of course. So one of the questions were the vaccines rushed in development and clinical trials? And if so, what are the concerns around that?
That's a really good question. When I hear rushed, what I take from that term is where things skipped or where they missed, where corners cut. So I will say that no corners were cut regarding safety and the well-being of participants in the studies. But there were operational steps that were hurdles, I would say, that were overcome really quickly. And I think a lot of that had to do with the federal government, utilizing taxpayer dollars to support the pharmaceutical companies to manufacture these vaccines at risk. And what do I mean by that? Well, typically when vaccines are manufactured at a large scale, it's done after a phase 3 trial, after the product or the intervention has determined to be not just safe, but also efficacious, that it works to do what it's supposed to do. However, the federal government at risk invested in the manufacturing of these vaccines early on in the process before that was determined. So that was the at-risk part. And I think part of that decision was that we really needed to help mount a response to COVID-19. There was a lot of harmonization in how the clinical trials were conducted. And this harmonization is like next level harmonization. Like when I say next level, I mean next level harmonization. Like federal agencies were talking to each other and really connecting in ways that I have never seen in clinical research before. And a lot of this, I think, was to help move this process forward as quickly as possible and reduce sort of the typical hurdles associated with it and the red tape. But the FDA reviews of the safety data at each phase of the clinical trial process absolutely continued. And there were several groups that also constructed their own task force or review panels to ensure that they were also able to not only review the data, but provide perspective about the analysis and the results. So one of those groups is the National Medical Association, which is the largest healthcare provider network focused on Black people in this country. The other thing I will mention is that, Black and brown people are visible all up and through this research process. So, I have a cadre of colleagues that I work with in the operations center here in Seattle, but the 4 historically Black medical colleges are also conducting the clinical trials. They're part of our network. So they're doing the COVID trials as well. In addition, we have Dr. James Hildreth, who is the president of Meharry Medical College, which is one of the 4 historically Black medical colleges. He's actually on the FDA advisory panel that reviews the data, among other Black providers and experts that are connected. So there's a lot of people. And of course, I can't forget Dr. Kizzmekia Corbett, who co-led the development of the vaccine itself that was tested in the Moderna trial, who's a Black woman from the South. So I will say again that the process was moved quickly because there was an imperative to do so, but there were no safety steps skipped in the execution of these trials.
Thank you for that.
Thank you. I wanted to ask also, just speaking of just a trust and all, and what do you think is needed to build trust within our communities, not just the POC community, but also the queer community?
I have quite a bit of perspective about this, but I want to, I think Kay should probably go first.
Well, I think when BIPOC and QT BIPOC people are able to be vaccinated, and to the extent that they feel comfortable sharing their experiences with being vaccinated, that transparency can help build trust in the community, right? Like, I think it's very different when you get to see your friend get the vaccine and how they respond to it rather than just statistics. I personally shared my vaccination journey and the side effects that I experienced, because at the time in Massachusetts, when I received both shots, I was among the 3% of the state that had gotten that. And that was about 2, 3 weeks ago. So if I knew that 3% of the people in Massachusetts got both shots, I was pretty sure that there would not be a lot of people like me, queer, trans, Black, and brown people, right? So I was like, the only thing I can do right now is at least share what it's like. And if anybody has any questions within my community, to let me know. And I, told people what my side effects were like. I was very transparent about it and my own skepticisms with it too. So I think for us, we are our best resources sometimes, the only resources that we have. And so by us sharing our stories with it, we can help each other. I also think maybe this is a question later in the conversation, I hope, about trust. This situation puts so much impetus on the individual and the choices that we make, if we wear a mask or not, right? If we are following these guidelines, are we traveling? Are we hanging out indoors with people we don't live with? What are we doing? Our own social responsibility. And so I think that's also a component of trust that I hope we get into, right? Like our individual actions and the things that I'm seeing, posted on social media, frankly, give me a lot of distrust. Like I see people posting a bunch of stuff. They're hanging out with a whole bunch of people. And I'm like, we're in a panorama, like, I don't know if that helps me build trust, right? When I see the personal actions and decisions that my community is making.
Thank you for that. I really appreciate all of that, especially that last point, the panorama. Some of my kids have called it the pornographic. I don't know if I can say that, but I just did. But no, but I think that I have 2 thoughts about the question of trust. And, I think first to start with is that, providers and researchers need to demonstrate trustworthiness. And to me, that comes from breaking down these barriers and these walls that sort of separate people from concepts and separate people from each other. How do we make science more accessible? Do we need to use technical jargon to communicate things? No, we don't. We can talk plainly. We can use regular everyday language. And how do we meaningfully involve communities, not just in their own care, which I think that absolutely needs to be done better, but also in the research process? Like, how do we make it more interesting, more attractive for people to want to learn more about and find out more about? There's way more opportunities to engage in this process beyond being a participant in a clinical trial. Learning more about the clinical trials process is certainly one way. And sort of learning about, diseases and infections and immunology and vaccinology, there's a way to dig into these topics that will be empowering, affirming, but also like not put you to sleep. So, so that's sort of one angle. I think the other angle is, how do we address this? I always go back to the systems level, because that's where we drill down to the local, but I feel like at the systems level, we need to do so much better. And again, I go back to, how do we recognize the agency of people, right? The autonomy of people to have a responsibility and decisional choices and power over their own being, their own presence, their own movement through life. And recognizing that everyone is an expert of their own lives. And I may have clinical advice, or I may have a medical perspective, but that does not mean that what you think and believe and feel becomes irrelevant or minimized. And how do we, I call it power sharing. How do we think about engaging people in a way that it doesn't become, I have power because I have a degree and I'm in a position of authority over your experience in this situation, whereas you recognizing you also have power because, one, you don't have to be here. Two, you have agency over your own life. Three, you could be doing something else, I would, I don't want to talk about what I would rather be doing, but there's a reality there, I think, that we need to acknowledge. And I think that systems-wide, the systems have not done any justice to people, because there's been a constant denigration of the individual and personhood that people have.
I know it's your turn, Kenya, but I have one question for Kay. That's going from trust. How do we create connections and synergies with community leaders?
Yeah, that's a really important time right now. Mutual aid, I feel like, has become a term that we've seen a lot more now because of the conditions that we're in, COVID-19 in particular. So mutual aid has long been a tactic used by organizers and marginalized people, but certainly now, right, people lost their jobs en masse, so we needed to move resources quickly. I think we're still seeing that now, particularly in Texas, right? People are creating their own campaigns to help each other out. So this year now that we've been in this, I think has certainly shown us both that individuals have a lot of power, as Dr. Wallace was talking about too, and our actions have consequences and impacts on others. And we've certainly seen, these like horrible representations, I think, of people who are still gathering in mass and really don't care and fighting each other about whether or not they should wear a mask, right? It's become politicized, if you should even do this or not. And the backlash that comes when you challenge someone who's not wearing a mask, I mean, it can actually endanger your safety. And, the particular demographics that we've seen that are vehemently against wearing a mask, right? And then I've seen, such great humanity happen too, where people help each other out, creating these mutual aid networks. So to your question, how do we help? I think being attuned to the mutual aid organizations that are happening. In my neighborhood of Chelsea, there's a few organizations here that have been leading that effort, and they ask for certain things, right? They're asking people who are able to physically volunteer to do that. If you're not able to do that, you can donate disposable income if you have that right now, or other resources that you're able to donate. So to your question, identifying who in your community is doing these things and taking inventory of what you're able to offer.
Thank you. Set. All right. Want me to take the next one, Nancy? All right. So COVID-19 vaccines, or can you talk a little about, or answer this question rather, can the COVID-19 vaccines cause infertility or miscarriage?
No, we've seen no data to suggest that that's even possible. There are people in the COVID-19 vaccines who, so persons who were pregnant at the time of enrollment in the study were not eligible, but people certainly became pregnant during the course of being enrolled in the study. So we do have some data on how the vaccines work in pregnant persons. But there are some studies that are coming out to look specifically at pregnant persons and the COVID-19 vaccines. Those should be starting up rather soon, as well as COVID-19 vaccines in adolescents and children as well. So.
I was actually going to ask about that, about COVID-19 and children. Right now, there's a lot of talk about, the schools and everything like that. Could you talk about that? Where we are, what you've seen, what looks hopeful, what doesn't, around COVID-19 and children. And I actually have another question to follow up right behind that one.
Yeah, so again, the media did quite a bit early on to suggest or to infer what, the how susceptible young people were to the disease and symptomology associated with it. So, but getting to your question specifically, none of the studies, none of the phase 3 trials conducted to date have included children, because that's not typically how the research is done. Typically, research happens in adults first, before children, because children are considered a more vulnerable population. So now that we have some data showing efficacy for adults, then those vaccines will move into clinical trials for children and adolescents.
Awesome, thank you. So my follow-up question is actually a question I've heard a lot of people ask, is if someone is pregnant and they become, in fact, it's not even about the vaccine. Someone becomes pregnant and during their pregnancy contract COVID-19, does the COVID-19 affect the unborn child in any way?
Yeah, I don't have a lot of information on that, unfortunately. I would have to dig through some articles. I know that there are people who are looking at this, and who are looking at it very, very closely. So.
Thank you. No, thank you. That's just a question, folks have. Um,
Give you back real quick. What's the recommended age group for that youth that we're speaking of? Because youth goes from people that have folks have a 3-year-old and you still have 18-year-olds in high school at some point, 19-year-olds. What's the actual recommended age for the vaccines?
Yeah, so for the ones currently under EUA, Pfizer is 16 and up, and Moderna is 18 and up. So the trials that would be done looking at children and adolescents would be younger than those ages. And how young they are, I can't say, because I need to first see, the protocols for those trials. So, but I think it's reasonable to assume that, they will go as low as they can, based on the data that we have in the other trials.
Thank you. So just want to let everyone know if you have any questions, any more questions. I keep on looking over at the live feed. If you have any more questions, please throw them in there. We'll try to get them in. Ironically, the questions that's been coming up on my end have been questions we've been asked already in the list, so it's been perfect. I know you talked about this a little bit, Dr. Wallace, about the misconception of vaccines, injecting the virus into your body. Um, you know, just for final clarification one more time, because sometimes we got to repeat things, right? Can getting the vaccine give you COVID-19?
No, it can't, for a couple of reasons. The first reason is because COVID-19 is actually the disease or illness. The virus is SARS-CoV-2. I know that isn't always messaged well in the media space. So the virus is SARS-CoV-2, and SARS-CoV is basically severe acute respiratory coronavirus 2. And so that's where we are. There is no, live, dead, weakened version of the virus being used in any of the vaccines. For the protein-based vaccines, they're using laboratory manufactured pieces of the spike protein. So those aren't so you're not getting any actual, virus as part of this process. I will mention, because this comes up quite a bit, that, there are some vaccines that use, weakened versions of the virus, or dead versions of the virus. But typically those vaccines are for viruses or for diseases that are less communicable than this, and are less deadly. So typically, we want to stay away from using, viruses, live, dead, or otherwise, in vaccines for more serious, viruses that have a higher, what we call, attack rate or death rate. That would include HIV as well. So I just wanted to mention that. The other thing I will mention is that, what the viruses are providing you is basically a photocopy of the spike protein on your body, into your body rather, so that your body then sees the picture, the photocopy, and says, hey, this is the thing that you need to look out for. So it's sort of, I think I'm not on this particular app because I don't feel like I'm in the demographic, but it reminds me of how my kids use Snapchat. So you can post a picture on Snapchat, and like in 24 hours, it disappears. Like, that's how I think about this, right? You're basically showing your body a snapshot of what this is supposed to look like, and then it disappears. And your body then remembers, hey, I remember that picture. I remember, this thing, and now I see it. It's right here. So.
Yeah, awesome. Thank you. I'm getting multiple questions into a couple different devices. I do want to circle back, because you said something about SARS-CoV-2, and every time I've used that in my discussions, people look at me like I'm talking French, right? And then they're also saying, there's a thing about, this is so new. How did they develop the vaccine so fast when there's so many other things they haven't had vaccines for? So can you, and you told us what SARS means, but how long has SARS-CoV or whatever been around? Is it really something new? Because people are saying, COVID-19 has been around for so long, but I think there's a disconnect between understanding that SARS-CoV-2 is COVID-19, and that SARS-CoV has been around for a while and shown up in a couple of other communicable viruses that we've had in the past. So could you talk a little bit about that?
Sure. I'll jump in, and please let me know if I miss something.
Okay. I know I asked a lot in one question. I'm sorry.
So SARS-CoV-2 is the virus. COVID-19 is the disease. And then an analogy that I would use that might be relevant for people is HIV is the virus and AIDS
Mhm.
is the clinical syndrome,
Okay.
right? So it's SARS. So SARS-CoV-2 is the virus that causes COVID-19. In much the same way that HIV is the virus that causes AIDS diagnosis. So, um, but I think that there's a lot of questions about the virus, in particular when we think about the vaccine. So for the virus itself, this is a novel coronavirus, but it is a part of a family of coronaviruses. So there are other coronaviruses that we already know about, influenza being one of them. And there also is the predecessor to SARS-CoV-2, which is SARS. And then there's MERS, the Middle Eastern Respiratory Syndrome. And so there are other viruses that have come around that have sort of been a part of this coronavirus family. And why it's called coronavirus is really because of the way that the spike protein looks. It's sort of shaped like a crown. So they've given it the nickname coronaviruses because they all have this sort of similar characteristic.
Wow.
So that's where the name comes from. And so SARS and MERS, have been around for a while, obviously. And the work around the messenger RNA vaccine specifically is also not new. Messenger RNA vaccines have been used to respond and to test the response to Ebola and other viruses, including influenza and others that are part of the coronavirus family. So we're looking at well over a decade of work in messenger RNA vaccines. I think what's new is that I think this is the first time that the messenger RNA platform has been tested in this number of people. So I think that's sort of one of the novel things about where we are now with the messenger RNA platform, but it is not new by any stretch of the imagination. The other thing that I wanted to mention about this, I lost my train of thought.
Okay. Thank you for that. That was actually very, very, very important. The information you just gave, because there is a lot of, I have a family member that sends me things on YouTube all the time, and that's their point of reference. When I'm like, if you learned about it on YouTube, question that. And that's where a lot of this stuff comes from. So the next question I have is actually for Kay. What have you seen as the biggest challenge in working with emerging health professionals who don't have our lived experiences? And Dr. Wallace too. I'm sorry, I didn't mean to just
Yeah.
say Kay.
Well, I think in my experience, trying to be open to other lived experiences can be a challenge. If just because something doesn't happen to you doesn't mean it's not happening, and especially concerning for folks in the sciences, there's a lot of quantifiable ways that we can prove that there's a legacy of discrimination and oppression, but yet, it's not enough for some people. They may think that we're post-racial, we are post-racism, right? Which is why using this particular year as a new case study to reintroduce these concepts of race and racism to medical professionals is what I've been focusing on. So particularly over the past 6 months, we had the onset of the pandemic and we had widespread mass demonstrations and uprisings for racial justice at the same time. And COVID-19 is a racial justice issue. But is it being framed as such? It's a racial and economic justice issue too. So for health professionals to see all those things, we teach the social determinants of health is a widespread practice too. But even with that, it's not digging deep enough into the roots of this country and its structures. So those have been a lot of the curricular educational challenges that I've worked with. But there's a really broad spectrum of the students that I've engaged with. There's students that are very invested, very well versed, not only in lived experience, but people who have been doing this community work too. And then there's folks on the other end of the spectrum, who haven't quite been immersed in that, but they do care and they do want to know. But I will tell you that there's also, an extreme side, right? People who do not believe that racism is real.
Mm-hmm. Yeah. Yeah. Thank you. Dr. Wallace, did you have anything you wanted to add on?
Nothing other than what Kay's already mentioned so eloquently. So no.
Awesome. Okay. Nancy, do you want to take the next one? Oh, you muted.
I wanted to see which next question was. Let's see. Here's I would hope an easy one. Where's the best place to look for COVID-19 vaccination updates? Other than the other than the CDC, I would say.
Okay. If you're thinking about vaccination distribution, or if you're thinking about race and ethnicity data associated, I would absolutely start with your local county health department first, and then maybe the state health department. Both of those groups should have put up dashboards that provide the data on the distribution and how race and ethnicity data sort of overlays with that distribution. So.
Okay. Have any resources?
I think it really varies in your state. This is very piecemeal rollout. I see so many websites popping up. People have, created different strategies to find it. So I unfortunately don't think we are a very organized nation in terms of distribution, right? Which this is an example of that. In one state, you got to go to this site, and this other state, you got to go here, and a lot of it is done online. So for our communities who do not have internet access, who have language barriers, what does that mean? It's probably a formal network of people who are doing this information distribution. For example, in my community right here, this is a population of Spanish speakers who may not have computer access. So these folks, these organizers are going door to door, they're texting, they're making phone calls. So this is about getting plugged into the resources here, which are going to vary based on where you live.
I agree. One of the things that we're doing here also is constructing or helping to create community vaccination sites and community spaces that people already go to, so they don't have to go anywhere different. So we're looking at a couple of churches and BIPOC communities, as well as mobile testing or mobile distribution sort of vans that will go out. One of the things that I have been pretty vocal about is I almost feel like we need to be at a door-to-door sort of scenario right now, honestly, with our community. So that's the banner that I've been waving a lot lately.
Yes, go door to door. I know here in DC, we have a pretty decent website, pretty good website, coronavirus.dc.gov. It's updated daily. And our mayor, she does a broadcast almost every day, giving you whatever updates, numbers, any late breaking information. And if you aren't like me that like lives online, you can sign up for updates, and then they'll send you an email or a text every day with whatever's doing. It's been very beneficial for the conversations I've been having here locally. So thank you.
And the same can be said for Maryland. I'm in Maryland. At least twice a week, Governor, what's his name? Larry
Hogan.
Yes. Has very long, at least an hour-long briefings, and also the county level. But the problem with that is, and which follows up to my question, is it's in English, right? They're doing well with the ASL, but it's always in English, and I usually catch it, to be honest, on Facebook Live, because I'm old that way and I'm still on Facebook. But what I guess the question is, why haven't we seen a bigger media presence, be that TV and radio for Spanish speakers? And that's also, with the whole trust and everything. And because for one, you'll have the websites where they'll have them in Spanish, but then it's to sign up for your vaccinations, but it's not 100%, right? And that's one of whoever wants to answer that. That's a big one.
Well, why haven't we seen it, right?
Why haven't we seen a bigger media presence, be that TV or radio?
Spanish. Yeah. I mean, for me, the question is it a priority? You know, are folks thinking about the different communities that are in need right now, particularly in this case, people who speak other languages or Spanish? And I haven't seen that in Massachusetts. I have seen that work fall on community organizers in my neighborhood who are translating the materials, who are advocating for, a vaccination site here where people can speak Spanish and do that because clearly these communities are not a priority when it comes to vaccine distribution, right? But this is a priority in terms of the labor force, right? So why hasn't it been? I think it's because low income bilingual speakers or English people or folks where English is not your first language are not thought of right away. We are communities that are considered largely to be dispensable, and then they have the audacity to label you as an essential worker. But, if you were so essential, they would make sure that you could find out, right? But that work falls on us and our communities to make sure that we take care of each other is what I'm seeing, and that's what we're doing.
Dr. Wallace.
Can you repeat the question, please?
Why haven't we seen a bigger media presence for Spanish speakers, for those who, I guess, to build that trust on looking to get the vaccination?
Yeah, I'm not sure. I think in terms of the distribution, as I mentioned, the CDC has sort of ceded that to the states, and many states have ceded that to the local jurisdictions. So I think it's a combination of people not thinking about it and not sort of prioritizing it. I know that in the vaccine trials, there was quite a bit of messaging that was in Spanish media, print, radio, and TV media, because we launched those campaigns. So, but in terms of the distribution and the rollout aspect, I think that needs to be prioritized. And honestly, I think that the priority should be beyond English and Spanish. It should include, Portuguese, as well as, the multitude of Asian languages that are spoken in this country, as well as other languages as well. So I know that there's some health department jurisdictions that have done some work around translating education materials into lots of different languages and providing those materials to the community organizations that provide services to those specific communities directly. But yeah, I can't say anything more about the mass media piece, except that it needs to be prioritized.
Thank you. So I have a question. It's a long one. So let me get through the question. The person says, I have a question. It went away. All right. I have a question in regards to social distancing in a multi-generational house. There's 8 of us, 4 generations ranging from ages 3 to 85. My brother and uncle are restaurant workers and work daily, and there's a few cases at my mom's job too. How can all of us best work to prevent exposure in the house, especially if my grandma ends up being able to receive the vaccine? Thank you so much for talking about the skepticism of the vaccines in our communities. Some family members definitely feel that way.
Yeah, I would actually start.
Hold on, there was a follow-up. Are folks able to wear masks indoors? Are there other rooms or floors in the house, in the home? Oh,
I typed that. Yeah.
Okay.
No worries.
Go back to you, Stefan.
Yeah, I think I think being skeptical is important. I think where we are in this process that people should, well, I don't like shoulds, that having a healthy sense of skepticism, given everything that we've talked about in this conversation, to me is completely understandable and justifiable.
Mhm.
I would offer that if there are opportunities to physical distance within the house, to consider that, and also to consider getting tested on a frequent basis, to ensure that you're keeping up with your status in this regard. I know many jurisdictions have rolled out some degree of contact tracing as well. So this would be really useful in that regard also, so they can track um, and monitor how virus is moving through the community. I think that would be very important. But sanitizing surfaces, particularly high touch point areas, masking, and if someone does acquire the virus, don't necessarily treat them like a leper. But I do think that isolating them during the time frame that their symptoms are present is important until I think the time frame is still 14 days. So um, opening the windows whenever possible to allow fresh air to come in and circulate through the spaces is really important also. Um, and again, just doing everything that you can. I mean, given I don't know where you live, but I know in many places, square footage in homes is an extreme premium. So, any opportunities you can to isolate people with symptoms, but not ignore them, but just sort of relegate them to a certain space in the home, and again, sanitizing and wiping those high touch point areas, and please try to keep small children away from people who may be symptomatic. So, because small children have a tendency of putting everything in their mouth and touching their eyes and their nose, and that's exactly how the virus is spread. So,
Thank you. Thank you for that. And thank you for the question. Nancy?
Yes. For folks that don't trust the government, are there any orgs that we can trust or they can trust? We can all trust.
So I'm one of those people. I'll just say it. I have a, I don't know, robust skepticism of this entity of government. So, I mean, again, it depends on the person, right? The institutions and entities that I trust may be different from those that you do. I think, for example, the work of these like community-led vaccination sites help build that trust because it's people like you, right? So the folks here in Chelsea or like the Black Doctors Consortium in Philadelphia, I think can help with that. It's not a government entity, it's a people-led entity that are distributing the vaccines if that's the particular area of skepticism around it. So I think for those folks trying to uh, know the people that are running these sites or look into the organizations as much as possible may help with that. But I'm with you.
yeah, I think that uh, going to trusted sources is critical. And if you don't have trusted sources, I would ask that you consider reaching out to someone that you do trust to get connected to somebody or some people. And if you aren't sure how to do that, I'm more than willing to connect you to people in your local area that can provide you some perspective. We're connected to in the upwards of 80 or so different national organizations, from the NAACP to different medical associations, different civil rights organizations focused in the Latinx community, and other groups. So happy to try to connect you to somebody and some people that can provide perspective in addition to being able to connect with my network. I provided quite a few resources in the chat. Many of these are websites that will take you to tools and education materials that you can take and share, with your networks as well. So, and of course, if you have any feedback about anything that you see on these sites, please feel free to reach out to me, questions, comments, or concerns.
Yes, thank you for sharing those resources. I am opening them right now because we're going to post them on both of our platforms, right? On the Latinx History Project and Center for Black Equity, to make sure they are accessible. And I will say this, I am on one of those networks, and I do get emails from Dr. Wallace all the time about something new going on. So yeah, they're out there. Nancy, you want to take the last one?
Yeah, we'll do. And just, let's see, here, last question of the evening. How do you encourage Black and brown queer people to not only trust, but to get a COVID vaccine or vaccines?
Well, I am a vaccinated person. I got the Moderna vaccinations, both rounds, a couple weeks ago. I'm still here. I haven't noticed any abnormal things happening to me. Although I will tell you, I had a hard time with the side effects. Like, to be real, it was not fun or easy for me. With the first round, was out of commission for about a week. And the second round, I had like a very intense 30 hours after the second shot. So I'm not gonna say it was like, easy for me, but that is what happened. If anybody, wants to talk about my experiences with it, if that will help you, I can share that for sure. So I don't know. I think it's a personal choice, right? You will decide if you want to do that. I'm not going to say everyone should or shouldn't do it. I think it's up to you. I highly encourage it as someone who has done it, because I personally, want to make sure that I'm doing everything I can to keep the people around me safe. And if there's any possibility that this vaccine will reduce the transmission to others, if it will keep me out of the hospital so that people that really need that space can have it, then I will do my part. And it's not just the vaccine, right? It's all the other behaviors too. It's wearing the mask, it's social distancing, it's avoiding, all the things that make our lives more high risk for other people. That's what I was kind of hoping we get to today, are these like decisions that we are forced to make every day. Is now the best time to go fly to a tropical vacation to a predominantly Latinx country that does not have an American infrastructure? But I really want that cheap flight right now, so I'm just gonna go. And I don't know if we're asking ourselves those questions, or if people are just saying like, I don't care. I deserve a vacation right now, so I'm gonna go to the airport. I'm gonna, possibly expose all the folks that work there, and the flight attendants, and the people that receive me on the other end of this plane. And those are the things that I wish that, we talk more, because I'm truly concerned that people are gonna get this vaccine and they're gonna throw everything out the window. They're gonna say, okay, I'm vaccinated now. It's all good. I can go party. I can go travel. I can do everything. And it's not a pass. I have been extremely I don't know, restraint in everything I've done over the past year. And even with this vaccine, I'm not like, okay, good, like I'm gonna go do everything I want. But I'm concerned that we're just gonna disregard it. So as this now becomes more widely available, I hope that we don't, let up. We just hit 500,000 deaths.
Yep.
More than that. That's more than all the wars this country has engaged in combined. And I'm just like, are we just desensitized to this? As long as it's not me, it's fine. Or because I don't die, it's not a big deal. And that to me is truly horrifying.
Yeah, yeah, true too. You said something and it made me think of another question I'm going to ask, but I think I'm going to direct this one to the doctor. Side effects. Why do folks get side effects from this vaccine that are a little bit different than other vaccines? I know we said that question, but
I want to answer that question, but I definitely want to dovetail off of what Kay was talking about. And, I think we have an opportunity that we are recognizing that our society is rooted in individualism, and thinking about how do we move out of that, and become more communal. And first, I think it's about recognizing the climate of fear that is continuously propagated in this country, and in part by the media, and by forces, and I will use K's, the them, who are out there, who are who have a vested interest in seeing people at each other's necks, honestly, which is working against our collective good. So I think that the desensitization is real. I think the concern about how people will react at a micro level is real, and it's important. I myself am looking forward to, well, first I will say that I am a trial participant in the Novavax trial. So I am, in addition to all the other things that I'm doing, I'm also in a study. But beyond that, I will say that I'm looking forward to getting unblinded soon to learn whether or not I received the vaccine or the placebo. So I think that that's really important to mention, because when I think about the side effects and the reactions, to sort of go into your question, Kenya, I think that part of the reason why people experience reactions to vaccines is because you're sticking a needle in someone's arm with something. It doesn't really matter what it is, right? Like you're penetrating the skin, so you're going to have a reaction of some sort, sore arm, and some of the reactions that people are having are expected. The headaches, the nausea, the stomach, the those sorts of things, the fevers. All of those things are expected, because what is actually happening is, for the most part, minus the sore arm, is your immune system is working. And anytime your immune system begins to sort of be triggered and start to do something, you're going to have, these kinds of symptoms, mostly. Not everyone will have them, and not everyone will have them to the same degree. And because everyone is unique. And so, but most people will have some kind of a reaction. And so those are expected, and those are common. The less common reactions that we're seeing from the vaccines are anaphylaxis, which is a severe allergic reaction. So the remedy is to provide epinephrine or an EpiPen or EpiShot, and that will help to reduce the impact of that. And typically, when people are in vaccination spaces, they have protocols for all this kind of stuff. So if a person has a certain kind of reaction and it's perceived to be anaphylactic in nature, they'll get the EpiPen administered, and 911 will be called so that they can do a thorough medical evaluation and assessment to the person. And that's for the person's safety that this protocol and treatment plan is in place. But those are the things that we typically see. And like I said, what we're seeing here is primarily because people's immune systems is reacting to what they perceive to be a foreign invader. But this is what we want. We want that kind of a reaction. We want a reaction from the immune system. So hopefully that answered your question.
No, it did. It did. I was here thinking, I was like, I wish I could carry around like K in my left pocket and stuff on in my right pocket. So like when these questions can be like, here goes your answer, because you're gonna answer right. Because you guys answer them so like in plain English. And I think that's part of the issue, is people are getting things on the media or whatever, and it's not plain English. So when it's not plain, people kind of make their own like interpretation. So I just want to thank you both for really just, this conversation and just, getting this information out in our communities. Nancy, I don't know if we have any questions on your end, but I have no more on my end.
Oh, I think it's time to wrap it up. Everyone. Hope we answered. I know I learned a lot. So
Same here. Yes, thank you. Thank you both. Thank you everyone that's watching. Thank you everyone that will be watching. Because this session will live on our social media pages. I've been sharing it in a couple groups. I'll be sure to direct people when they ask me questions and they say, you know, well, what's such and such? I'll be like, well, go to 15 minutes in the presentation and I'll answer your question. I can't thank you enough. Thank you for spending your evening with us. Thank you again, everyone.
In case we don't, Dr. Wallace shared those on Facebook. It's on Instagram and Twitter. It's very simple, you know, .com/prevent COVID-19.
Mm-hmm.
So just in case you're not trusting or you're looking for a different source,
Yes.
that's where, yeah, they're very simple, direct to just prevent COVID-19 and on 3 platforms.
And please engage us on social media because we have, I mean, our team that manages our social media presence, they have all the information. And, you know, if you ask them a question and they aren't able to answer it, they'll reach out to myself or, you know, one of the other investigators or clinicians or researchers to get, you know, an answer to the question. So appreciate the opportunity. I appreciate meeting you all that I've not met before, especially you, Nancy, and UK. Great to connect. I look forward to connecting again soon.
Likewise, and thanks for your work.
Thank you all again. All right. Take care, everyone. Have a
Bye.
good night. Bye.
See ya.